All right. Well, welcome back, everybody. Good to see everyone. It looks like we're still missing two individuals. It looks like it may be John and Catherine. We'll try to reach out to them to make sure that they get on, but if anybody wants to shoot them a text or a message, we obviously would appreciate them on the call.
Eric, they're trying to find the Zoom link. So I don't know if anyone could just send them the Zoom link directly. I had trouble finding it myself.
Okay, I'll have David send it to them right now. It should be in the meeting invite that was sent out, but we will email it to them and they can hop right in. So again, we'll run this and make sure that everybody on the live stream understands who's part of the working group and who's speaking when they are. So we'll go around and do introductions, before we get into the substantive conversations. And I'll just call out individuals. And if you just, again, want to introduce yourself, who we're with and what seat you have, that would be great. So first two people I believe are not on the call yet. So we'll start with Paul.
My name is Paul T. McCarrier. I represent the Caregivers of Maine and the Patients of Maine. And I'm a part of the Maine Cannabis Coalition. I own one mill in Belfast.
Susan?
Susan Meehan. I own a pediatric-focused caregiver business, Maze Mamas, and I'm the chairperson of the Maine Cannabis Coalition, and I'm here to represent the caregivers and patients. Thank you.
Joel?
Hey, everybody. Joel Pepin, Jar Cannabis Company. I'm here as a caregiver representative.
Dave?
Yes, David Vickers from Origins, and I'm also a caregiver representative.
Josh?
Good afternoon, everybody. Josh Quint with Canuvo, representing the medical dispensaries.
Heather?
Heather Sullivan from Curaleaf, and I am also representing the dispensaries.
Barry?
Hi, Barry Chaffin from Nova Analytic Labs, and I am representing the testing facilities.
Alex?
Hey everyone, I'm Alex McMahon with Medco, and I'm representing product manufacturing.
Patricia?
Sorry, I was muted. Hi, I'm Trish Callahan, and I'm a patient representative.
Michelle?
Hi, Michelle Caminos. I am also one of the patient representatives.
Sean?
John McDonough, I'm a patient representative.
Jamie?
Hi, Jamie Comstock. I am a healthcare representative, and I need to leave a few minutes before 3:30 today. So my apologies in advance for that.
Julie? Julie?
Hi, I'm Julie Milliken. I'm a nurse practitioner. I own Maine Medical Certifications, and I represent the medical community along with the patients.
Chris?
Chris Beaumont. I'm the marijuana compliance coordinator for the city of Portland, and I'm one of the two municipal representatives.
Rebecca?
Hi, Rebecca McMahon. I'm a staff attorney at Maine Municipal Association, and I'm a municipal representative.
And then it looks like John and Catherine have joined us. So Catherine? We're doing introductions. All right, we'll go to John. Oh, there she is.
John Black from Earthkeeper Cannabis, representing the caregivers.
And then Catherine, did you want to introduce yourself?
Sorry, I'm in the middle of moving, so I'm in my car. Catherine Lewis. I am a caregiver, storefront owner, and the chair of Medical Marijuana Caregivers of Maine Trade Association.
Great. I'm Eric Gunderson, director of the Office of Marijuana Policy. As usual, I have David Heydrich from OMP helping facilitate the meeting. And we also have Vernon Malik on the line, who's the Deputy Director of Operations here at OMP, who oversees our licensing and compliance team. I've asked Vern to join us. Some of the materials that we provided to the group do cover some of our compliance work. So I wanted to make sure that if and when we do talk about that, that we had Vern on to help facilitate that conversation as well. So Thank you, everybody. Like I said, good to see you all again. Welcome back to the third meeting of the Medical Marijuana Working Group. I just want to say I appreciate everybody's time. I realize that it's precious and valuable to everybody, but I am pleased with the first two meetings going back, looking at some of the conversations we had, again, in line with filling the information deficit here at OMP to help us report back to the legislature with recommendations and also how to formulate the rules, again, in line with the vision, what is going to benefit Maine patients, what's going to benefit Maine businesses and the stakeholders on this call. So again, just a thank you from me to you for taking part of this important work. I think first and foremost, at the beginning of the application process, we identified 4 dates to conduct this work. I think we could all agree that that might not be enough time. Certainly through the first 2 meetings, we've had great conversations, and I've kind of held back from cutting people off to keep moving because it's valuable, the work that we're doing and everybody's feedbacks and comments. But I think we've identified, in order to complete our work, again, both with a report back and recommendations to the legislature, but also to help putting together a framework and what a proposed rule should look like, I certainly think that we need to add another meeting, because I would imagine the last meeting, the vast majority of what that should look like is us kind of walking through what our recommendations are, what they should be, feedback for that, and then also an outline and structure of what a proposed rule may look like. And we still certainly have a lot of topics that we need to discuss that we certainly want to hear from you folks before we do that work, understanding that we even have a packed agenda today. So we've proposed to add a 5th date, and I hope it works for everybody. We can certainly send out a doodle poll to make sure that it does, or you can send feedback to David. But our proposal is Tuesday, December 14th at 2 p.m. Again, understanding that originally we committed to these 4 meetings. I think there's a lot of value in these conversations. And again, we're proposing a 5th meeting, Tuesday, December 14th at 2 p.m. I will have David send that out. If that's workable for you, please let us know. If it's not, also let us know. And then we can try to accommodate to make sure that we have the full panel here for that 5th meeting, because I think we can all agree that there's still many topics that we need to discuss moving forward in order for us to do the best job possible. Are there any feedback, any thoughts, concerns about the potential of adding a 5th meeting? All right, seeing none. We will have David send that out again. And again, please let us know if it works for you. If it doesn't, and we'll try to accommodate. And I would imagine that we would still slate it for another 2 hours. All right. So as I'm sure you've already noticed, and I think we have mentioned, we've sent around various materials to the working group. First, I want to, oh, Catherine, did you have your hand up?
I was just going to say that that's a great idea and we'll make it work.
Perfect. So as far as the materials, I hope you saw that the first 2 entire transcripts of the first and second meeting have been added to the webpage, the OMP webpage, in the working group tab. We've also made public the testing facility information and data that Barry discussed or was brought up on the last meeting. Chris Beaumont provided us a link to the State Fire Marshal's Office delegating review authority, so we can look into that. And then patient representative Sean provided an image for us to use as it pertains to microdosing in our conversation moving forward. And then finally, OMP has uploaded medical marijuana sales tax information that was requested from MRS. Again, some data around our compliance activities in the medical program, and then some other useful information that we provided to the Joint Standing Committee on the Veterans and Legal Affairs this year. And some of that might pertain to the first topic for discussion, but certainly when we get to the agenda item of useful data and metrics, we can cover some of those to see what we have to help determine different policy routes that we may take. So obviously, looking forward to today's discussion, we're talking about patient education in a program that's patient-centric, data in the role of municipalities. I will say, considering the amount of topics that we do need to cover, I apologize in advance if I'm in the position to need to cut somebody off. To date, we've been letting everybody get their comments and feedback out, but I want to make sure that we're super productive in these next 2 meetings, discussing a wide range of topics that we need to discuss, again, for us to complete our work, and obviously have time to circle back with this group about what that work is, the end product of that, to share with everybody. So I'm going to do my best to keep the conversation moving along. And if somebody has feedback or comment and we don't have time for it, we're happy to have that conversation outside of this meeting, just understanding that that will be part of the information and the dialogue that we do make public. So it's kind of part of the meeting, but just making time for everybody to have their feedback and comments heard. So any questions, comments, concerns before we launch into today's discussion? All right. So before we get into, well, I guess you could consider it part of patient education and centrism, patient centrism. We had a good conversation last week about testing. It seemed that the vast majority of the individuals on this call supported some type of testing, while understanding that costs associated with it does impact patient access in your business. But we had a lot of good conversations on that call. We did have some good internal conversations here at OMP, trying to find something that might find consensus, or at least majority consensus. So I just wanted to start with that and give you a proposal that we thought here at OMP would check both of those boxes, where it would certainly benefit the patients, understanding, again, the costs impacting patient access in your businesses. So I will give you, Paul, do you have a few questions? Or do you have a question?
Yeah, I guess, you know, what you said earlier about really sticking to the agenda and making sure we went through the agenda. I didn't see anything about testing on the agenda.
I guess so I would loop it into the patient education and patient centrism, and circling back from our last meeting. I mean, again, we're supposed to have these conversations for a report back to the legislature. Certainly testing would be a report back and wouldn't really be part of the rules, but we want to make sure that we can get some concrete information and consensus.
Could we maybe make that a whole agenda topic for the next meeting? Because it's such a big topic that I feel like if we're going to talk about what is listed on the agenda here, that we don't want to get bogged down in it. You know, we have a lot of data to go over. We have a lot to talk about with the patient part, and we also have the municipal part. And I feel like testing is going to bog us down here. So I'm definitely open to talking about it and hearing, you know, what you guys have been working on. But I did not see anything on the agenda that talked about testing. So I just feel like that was a big enough subject.
Yep. And again, we can lump that into patient centrism again. And from the substantive conversation, we do need to make progress on some of these conversations that we've been having. And that's really just our attempt to loop back and be able to complete our work instead of leaving all these conversations open-ended. Does anybody else feel that way, where we can't have a conversation of looping back from last week?
I think it's a great idea, Eric. Let's hear what you have. Obviously you guys, we give you some thoughts, and then we'd love to hear sort of what the Office of Marijuana Policies thoughts are also. So I think that would be great to hear from you.
Agree.
Okay. Susan?
Agree with that.
Agreed.
Agree.
I agree with Paul that testing is a whole topic in itself, and it's not on today's agenda, but if we want to scrap today's agenda and talk about testing again, then so be it. But I think it's a whole agenda item itself.
Well, I will point out we did spend over an hour talking about it last week, and again, just to make sure that we can move forward with our work. And I think everybody on this call would agree that it certainly fits into the bucket of patient centrism when we talk about the program. So again, the conversations that we had last week, it seemed like the vast majority of individuals on this call supported some type of testing. And again, making sure that it benefits patients within the program, but understanding that it impacts patient access and also the cost to your businesses. So I'm going to throw out a proposal and really just looking for feedback, comments, thoughts to help us continue to fine tune that And if we need to, we can also bring it back and make sure that we have an agenda bullet for the fourth working meeting if it's still being discussed, because we do have those other pieces that we want to discuss. But as far as testing, we were discussing maybe something around around final form testing. Not similar to adult use where it's upon transfer facilities. And when it comes to costs, we obviously want to make sure that we can minimize the cost, the impacts for patient access in your businesses. So understanding and looking at the data at the panels that are most likely to fail and would cause the largest health impacts to patients. So it would be final form testing for potency, which I believe is already in statute, but we just have the testing facilities up and running now. The molds and mildews and microbials for the data that we've been provided from Nova Analytics, and also the data that we have in-house from mandatory testing on the AU program. The molds and mildews microbials is really the most important and most likely to get through the stream of commerce, and then also pesticides. And that would be coupled with audit sampling, where the Office of Marijuana Policy could audit sample, and we could test for heavy metal solvents and water activity, again, to help minimize the costs. And that would be something where we audit sample. The office couldn't audit sample an individual caregiver or dispensary more than maybe twice a year. But I would love just to hear feedback on some type of rolled back testing regime that mitigated costs, but also benefited the patient. So Paul, you have your hand raised.
So, I thought this work group was going to be talking about the rules, not talking about statutory policy changes.
The purpose of the working group was both to talk about the rules and what the regulations should look like moving forward, but also a lot of unfinished business at the legislature and a lot of these topics for a report back and recommendations to the legislature to move the program forward.
But correct me if I'm wrong, the legislature voted down mandatory testing.
They did vote down mandatory testing.
Okay. So then I'm going to go to the inspections document that was set around. So I'm referring to the fourth part down on the second page. The first header is cultivation under question category. Second part is question for pesticide use. Third one is compliance count, which says 29. The fourth one is violation count, which is 2. Total evaluation is 31. Compliance rate is 93.5. So when I'm looking at this, I'm not seeing there being a huge issue with pesticide use as a potential problem within the program, as opposed to having caregiver renewals and caregiver assistant renewals being approved within the program, that seems to be more of a problem when we're talking about question category number 2, caregiver assistance, question, caregiver assistance, compliance count 210, violation count 91, total evaluated 301, compliance rate 69.8. So when I'm looking at this data, thank you again for getting this data together for us. What I'm seeing is that there seems to be more of a need to address the compliance with caregiver assistance than there is with any sort of pesticide use or even pesticide safety training.
Well, I certainly appreciate you pointing that out. I believe, and Vern can correct me if wrong, that has to do with compliance with individual caregivers or dispensary operators having the appropriate certifications to apply pesticides, not pesticide testing. And while I agree that there are other lower compliance rates, obviously the office as a regulator sets priorities on issues that affect public health and public safety. While I agree that we could do a better job making sure that we registered assistants, I don't think they're really on the same level with these. But I would appreciate any feedback that people have with our proposal. Again, it's a proposal that we had in-house after our conversation, and we're really looking for your feedback so we could move forward with something where there's consensus or at least majority of consensus. And if we're way off, you can just let us know that we're way off.
Eric, hi, it's Dave Vickers. One of the things that I've sort of am curious about is just when it comes to those items, like let's just talk about pesticides for a second. Again, I think, sometimes we just all have to agree to recognize that we're doing this for the patients, right? So we want people getting safe medicine. That's our number one priority. It really should be. And so the question I have is, when it comes to pesticides, what data will the Office of Marijuana Policy use to sort of decide or decipher the limits, right? Because that to me, I've done a lot of research on this, coming from a family of, folks in the medical world, and it seems like it's kind of all over the board, depending on what state you look at. So I'm just sort of curious, where that goes. Does that make sense with my question?
Yeah, certainly. So shortly, we're going to be moving forward with launching pesticide testing in the adult use. We're just trying to formalize a relationship between us and the Board of Pesticide, understanding that they are the experts when it comes to this stuff, and they can help us with determining just blatant use versus environmental effects, and be able to offer resources to help individuals correct any issues that they may see. But as far as what thresholds are we looking for, what detection limits, a lot of it is conversations with other states and some of my colleagues, and looking where others have set those detection limits. Obviously, it runs a wide variety, but right now, I don't know if this is groundbreaking or private information, but we're looking at what Oregon has set for limits, which are essentially middle of the road. They're not so low that you're going to ping every time for environmental issues, but they're not so high that really anything, even if it is contaminated or blatant use, would go flying through the system. So we've obviously worked with our colleagues, had these conversations with a lot of the testing facilities that are operating now, but also working with the CDC to find what limits would make sense for Maine and our industries. Having said that, the only clinical research that's been done on this, I believe, has been in Canada, where I can try to find it and send it around to you, but if I remember correctly, really to help mitigate negative health outcomes when it comes to pesticides and smoking pesticides, was much lower than any detection limit that I think is set up in any legal jurisdiction here in the United States. So that's kind of where we're at, and where we've had those conversations to determine what those thresholds and detection limits would look like.
No, appreciate it. No, thank you very much.
Barry.
Yeah, just to follow up on that, Dave, what we've seen in our laboratory before these proposed rules came out with pesticide limits, there were no limits. So we kind of set our own in-house based.
Yeah, exactly. Yep.
Yeah, based on what we could see consistently, and looking at other states. When the OMP came out with proposals for new limits, we changed our method to match those in anticipation of that. Which were in some cases factors of 10 higher than what we were already testing. In a comparison of failure rate between the limits we were using pre-OMP limit setting to what it is now, the failure rate only changed from 40% to 33%. So it's been our experience in our laboratory, if it's hot for pesticides, it's hot for pesticides.
Well, that's the thing I was going to say. I think when people are utilizing pesticides, they're utilizing them because they have problems, right? Severe problems. And so they're trying to mitigate those problems, and hence that's why they're coming in at those levels. Yeah.
I think it's important to bring up too, is we're talking about people who do outdoor cultivation, that there's a lot of conventional pesticides that are going to be used by non-cannabis farmers that could potentially drift or cause other problems, for people who are cultivating outdoors. And that kind of runs into the same problem when we're talking about the idea of mold, mildew, and microbes too, is that if you're cultivating outside, you're going to run into a lot of problems with being able to have any sort of living matter in your soil. And if you're going to be able to cultivate indoors, and you're going to try to use a living soil and get away from synthetic chemicals and be able to cultivate organically, is that, it's concerning, because you're going to have to be able to have a range and a variance to be able to account for that. Not even including people who are going to be possibly trimming it. I know that in other states, the trimmers have to wear masks, much like we have to wear masks indoors to prevent the spread of COVID, because they don't want to be able to possibly fail for a microbial test by just breathing on the cannabis. So that's just a concern, from just hearing from what everyone's been saying earlier. It's just, when we're talking about residuals and stuff. And so that's something I think we got to really consider, if we're going to be having this conversation about testing today.
Certainly. And just, Paul, I let you go there, but if anybody has comments, I want to make sure that everybody gets their time. So if you could raise your hand, I have a queue. That would just be the best way for the process to go. And what you're saying is true. I mean, there are environmental factors, and we don't want to let those products through to the patients at the end of the day. But there's certainly something there that we can work with. And I will say, in particular to pesticides, again, it's not a matter of, I mean, there's the blatant use of pesticides, which obviously as a regulator concerns us, and I hope it concerns everybody on here, but the environmental aspects, it would come with some type of support, education. I know the industry does a lot to help figure out where it's coming from and addressing those, but I'm going to go to my queue here. So Josh.
There we go. Thanks, Eric. So I guess I just wanted to say, I understand where you're coming from, Paul, and I think that also it should be acknowledged that the department has, come around to understand that instituting a top-down mandatory policy with all the same standards as adult use is not a practical suggestion, to slap onto the medical market. But there also, I think, is a pretty general consensus that something needs to be improved upon, that we can't just hope that it's all fine and that everybody is a good actor. I see you shaking your head, but it seems like an appropriate way to go forward, given the concerns, would be to have, again, a fairly broad range of passing testing criteria, and to slowly implement these things potentially over a couple-year period, so that there isn't a huge financial burden on the smallest operators all at one time. And so, for what it's worth, I think the department offering to, do random audit samples that they pay for and that they cover, taking that burden off of operators, is a good idea, and something that the state can be more proactive about. And so maybe it's that potency is useful, but doesn't have, in my opinion, the same public health connotations as the mold and mildew, microbials, pesticides, heavy metals. And so potentially there's, I think, a way to do, the mold and mildew and microbials 1 year, and then a year or two later you phase in pesticides, or however that works, but maybe potentially picking the groups of tests that are easiest and best represented by taking a sample that accounts for an entire crop, so that you're not taking 6 or 8 samples out of a small room or out of a small grow in order to be able to get it to market, and then having the state take over responsibility for some of the more complex stuff like pesticides downstream. I don't know exactly how all this would work. All of it is going to be uncomfortable. Everything in this industry is uncomfortable, but I think that there is a way to thread this needle to go slowly and carefully, slowly improve the general floor of quality for the product that's getting to the market without creating a catastrophic event that puts people out of business. That's, I think, the goal that we're talking about here, right?
Absolutely. Thank you, Josh. So we'll go to Michelle.
Sorry, it takes a second to unmute. Just quickly, I wanted to point out that in certain cases, somebody had mentioned, I think it was Paul, folks growing outdoors, particularly for people with limited income, it's a lot lower cost of startup to do that. So I'm thinking of it from an equitable standpoint and things like that too. But when we're talking about testing and people are growing outdoors, particularly to make concentrates, sometimes what you find is a concern of mine would be that the flower coming right off the plant may fail miserably because of mold, mildew. But the final product may be perfectly safe if they're processing it in ethanol, let's say, and then filtering it with a really with a really good filtration system and having it processed. So I guess I just wanted to bring up that point that to me, it very much depends what the final product is that the patient is getting, and making sure that somebody doesn't fail for something that is not going to be sold as is.
Yeah, that's an incredibly good point. And I may have not said it, but this proposal, this idea that we are floating to the group would be final form testing. So if that outdoor bud or outdoor flower was to be converted into a concentrate, it would be the concentrate at the end of the day that would have some matrix included for mandatory testing. So thank you for that. Heather.
Hey, I just needed to level set a little bit for myself on this. And Paul makes a great point about outdoor, and that just caused me to think, are we looking at setting the same standards for adult use and for medical? So would the pass fail line be the same across the two types of cannabis? And then the same question would apply to outdoor versus indoor.
My intentions, and people can correct me if they have other thoughts, would be you would have the same standards. I don't think it would be appropriate to have a higher standard of testing for consumers 21 plus than it would be patients.
No, I would have argued I would want it the opposite of anything, that there would actually be a higher standard for medical as it's a medical product. But I just needed to understand the direction that we were looking at heading in, and whether or not consistency with the adult use program would.
Yeah, as far as the standards and detection limits, I would imagine that, well, I would hope that they would mirror the adult use. Really what we're trying to accomplish, and it was certainly pointed out by Josh, is thread that needle to not necessarily require the full panels, understanding the costs and kind of dip our toe in it for the panels that really will have a direct impact on public health. So I have Sean, Catherine, and then Josh. I don't know if you have a follow-up, your hand's still up, but after that, okay. So Sean.
Yeah, I just probably a little bit confused over some of the replies going on here. I'm here as a patient representative, and I just want to make sure that without the patient, caregivers would be adult use. So making sure that your product is suitable as medicine. A couple conversations or a couple meetings ago, we tried to compare apples to apples. We're using medical marijuana the same as any medical system. If you're going to do that, if you're going to call this medicine, you need to make sure that it is tested appropriately. And whether it's indoor or outdoor, if you're going to use statistical data and say that nobody's complained about this or there's no data on that, you know, all it takes is one. You're here to help somebody, not poison somebody. And again, I'm here to represent the patient. I understand many of you here are making some sort of living off of this, helping patients, and I commend you for that. But I just want to make sure that people are fully understanding that in the end, it doesn't matter. Again, in the end, what goes on, how much it's going to cost. You have to produce a safe product for the person to be able to use it.
Thank you, Sean. Catherine.
Sorry, takes a minute. So in quick follow-up to the last statements, I mean, that's a given. Anybody who's here, that's a given. We care about the products that we're putting out for our patients. We were patients first, most of us. And so that's a given. There are people that may be in it just for the income. But for purposes here, I think we're all in agreement that we care about what our patients are getting. And if we make anybody sick, you know, that's just taking down the program before it even is finished. Anyway, I would like to make sure that when we're talking about testing, that we're looking at what statistics there really are, what problems really exist, We know that if people are using Forbid and Dr. Doom and Eagle 20, that they're potentially making people ill. We don't want that. I also think that we have to look at where it is in statute. We can't just make rules for a statute that doesn't exist. So we need to figure out what really needs to happen, not just because other states have it, but because it's important for our program here in Maine. And then we need to make sure that we have the standards lined up so that we know that across the different labs, we're going to be getting consistent results. So I'm looking at the statistics, the statute, the standards, and then what is our remediation policies going to be? I know we're talking about it being the final end product that will be tested. If somebody fails, are they going to be able to go back and do a remediation process through this? That's going to be really critical, especially since everybody is just getting acquainted with the testing here in Maine. This is an agricultural, when we talk about that, we want to treat it like pharmaceutical. Well, it's not a pharmaceutical. So it's not going to be tested like a pharmaceutical. It's an agricultural product with agricultural problems. The pest, mold, mildews, that type of thing. It's if we want to turn this whole industry over to the pharmaceutical companies, we're not going to end up with the program that we have. So again, I don't think that's where we want to go with it. And then as far as having outdoor, we do have to treat it as an agricultural. And I know that, one of our farm is beside one of the local apple orchards. So we have to be very careful with their overspray. I know I was working with a hemp farm in South Carolina, and they have requirements through the Department of Ag. If there's overspray that contaminates a product, a crop, and makes it unusable, then the contaminating farm has to make amends to the neighboring farm. There's strict guidelines around that. So I don't know if that's anything in our Department of Ag laws already. I haven't looked that one up, but that would be interesting to know. That's it.
Yeah, that's also a very good point. I can circle up with our Department of Agriculture and see if they have or what they have along those lines. And to your point, this certainly would require a statutory change that the legislature would need to make. And really, this conversation has more to do with the report back on some of these issues that have been talked about for what seems like years, and just try to come to a resolution so we can all move forward. But those are all good points. Thank you, Catherine. Excuse me. Susan and then Trish. And then I will cut it off to move the conversation along.
Okay, I just have, some questions and some math. I just want to know if there's data showing, documented harm, emergency room visits, pesticide exposure. And I don't know that there's any data that indicates that we're
think we lost Susan. So I think I caught the very first part of her question. There is some health data that we did provide from
I'm back. Sorry.
Oh, there you are.
Lovely
you were asking about
internet
data.
service here in rural Maine. Asking about data, and I don't know that there is any indication that there is a big crisis that we are exposing patients to harmful products. And I don't know that there's more or less in my whole wheat flour, strawberries, or
certainly
apples.
want to hear her point.
On
her
record,
question.
I test
Trish.
for any concentrates I used are cleared for pesticides, whether it's tested by the lab that makes those or. Sorry, frustrating.
Uh-oh. Trish, you're on mute, Trish.
Sorry, I
There
was
we go.
kidding. I was getting Susan that whole time, so I'm not sure why. That was weird. So I'm sorry. I wanted to say one that I think the proposal you guys threw out is a great place to start, and we all have to remember that you got to start somewhere in this. And so I think it's a good starting point. I would agree with potency I've heard from patients who are users who are microdosing. And for them, potency is really important. For me, so much, I don't microdose, it doesn't matter. But if you're looking to only get like 5 milligrams in a dose, then potency can be very important. And I liked the panel you chose for a first try, and then you guys auditing for those others, and then slowly implementing those audited ones into the regular panel over time. I think that's a great compromise. I think it's well done. And I wanted to second what Sean was saying. I have written and testified and spoken about the importance of small caregivers. You guys know that. I've harped to you guys about the importance of small caregivers in Maine. But with that said, as Sean said, you know, we have to have clean medicine. And while you'd hate to see it impact too much of the market negatively, at the same time, it's very expensive to grow marijuana in Maine indoors, especially if you're doing it indoors. And once you start having standards, it may be that not everyone's business model will succeed with standards. And hopefully that's a tiny percentage of businesses, because our small caregivers are a critical part of our program. But to try to not regulate because of those costs is I agree with Sean that making clean medicine is the primary concern. Thank you.
Thank you, Trish. Susan, we'll go back to you.
I don't know where I was cut off, but I just have difficulty with adding a $340 test panel to my final product when I know that the concentrates have already been cleared for pesticides. And I really think that we do not have an emergency in the state of Maine or in the country with people consuming toxic marijuana that they've been consuming, whether or not an illegal program, for a very long time. I don't see an influx of Maine's patients to Maine hospitals that are sick from pesticide poisoning. On record, I support only the spot check audit. And I think that that should actually be a spot check audit for pesticides. And say an inspector found a bunch of mold on your products that you're selling to consumers, then obviously a mold check would be appropriate. Dispensary is appropriate. But I think that you should be looking to solve obvious problems. The grow is littered with bottles of pesticides that are not approved for use on the product, and obviously there is cause and there is reason for OMP to audit and to do a test. I think we should be sticking to data and testing when it's appropriate. But I also believe that the program is self-regulating. A lot of us, most of us on this call probably do test our products and do check, like residuals. I tested residuals for the first couple years that was available, because I wasn't experienced enough to know that I got the residuals out of the product before it was formulated and bottled. Now I am, but someone working on this, on formulation and making medicines in the beginning very much ought to be testing for residuals. So on record, I support only the spot check audit. Thank you.
Thank you, Heather. And this will have to be where we follow up. I'm going to cut it off here. Incredibly helpful information. I do have one question around potency. And again, this is just to our perspective, it's important that the patient understand what they're ingesting, considering health outcomes, something that doesn't match up with the labeling. Is it something along the lines, if we did potency, and I'm taking this from two comments that I heard, is it realistic to potentially do potency for the same strain a caregiver dispensary is growing twice a year, just to ensure consistency with the potency moving? Is that just a crazy idea?
I feel like something with potency that we have to talk about is we're not talking like potency like with alcohol by volume, is that the cannabinoid potency interacts with the terpenes and other factors like microbial factors within the plant to provide the actual therapeutic or psychotropic effect. So potency by itself will not be necessarily as helpful to a patient, because it is only one factor out of 3, 5, etc. that actually adds to the therapeutic effect. So I think that's just an important thing when we're talking about potency testing to consider. And at the same time, when we're talking about actually testing different batches and stuff, is that the just as our seasons change, the growing environment can change. And just like as you do, a lot of people mix by hand still, mix their nutrients by hand. So you will get variations in the amount of nutrients that are added to the soil, whether you're doing a living soil, an amended soil, or adding bottled nutrients or mixing your own nutrients. So you'll have a lot of variations between different batches. And so I think that speaks, I think, to your point, Eric, of when we're talking about spot testing and the idea of having spot testing that'll specifically be able to address certain products. Because you could have a product that came off in January, and also as cannabis ages, its potency level can change. So when you test something in January, it may have a different test level in July. Thank you.
And then Alex and I will wrap this up.
Potency, I think, is necessary for some categories, potency testing, and maybe less relevant for other categories. So like for edibles, it's pretty important to know pretty exactly to the milligrams what you're ingesting. But for like flower and concentrates, it ends up playing less of a role. I mean, we have strains that test in like the 12 to 25% range that produce stronger effects than strains that might be in like the 25% range. Same with concentrates in particular. The best example I've found is, you can get a distillate cart that tests at like 91, 92% THC, and then compare that side by side with like a live resin cart that might test like 68% THC. A consumer would look at those results and think, oh, the distillate cart's going to produce much stronger effects, when really it's the opposite. The live resin cart produces much stronger effects due to the entourage effect. That logic doesn't apply for edibles and beverages. I think for that, it's pretty important to be spot on with potency. But I think, and really this is something that the industry as a whole has kind of just learned over the past like 5 to 10 years, that it's much more about the overall cannabinoid profile than just the THC potency. So therefore, I think that, from the patient access perspective, which of course is, the relevant factor there is cost. And from the public health perspective, I think that potency in vapables and smokables becomes less important than some of the other testing.
Awesome. Good feedback. I see Susan and Michelle have their hands up. This is going to be the first time where I cut off a conversation. Susan and Michelle, we can follow up with you and make sure that we document those conversations. So we do it in transparent process to make sure that we get that comments in, because this is incredibly helpful. So we are what I'm proposing right now would be, with this feedback that we've gotten, would people be in favor of us reconfiguring what it looks like, understanding a lot of the comments and feedback that we received, and bring a proposal forward next week to hopefully spend a little bit less time talking about it, but something that we could potentially as a group vote on? Does that make sense? Would people favor that? Okay, does everybody have their camera on? It looks like everybody does. So I guess I don't want to make it too formal, but if you support OMP coming back with a refined proposal around what this might look like, again, benefiting patients, but understanding costs associated impacts access and individual businesses. Can you raise your hand if you support us coming back with a proposal? It's unanimous except for Susan. Paul, do you have a question? Thank you for
Sorry,
raising your
what was
hand.
the question? My internet went away.
Oh, I'm sorry. We just took a poll or a vote that OMP will go back with all the feedback and kind of refine our proposal and bring it back to the group for hopefully a shorter discussion and a potential vote next week.
Yeah, I'd like to see it in writing, please.
Yep. Perfect. Okay. I'll take that as a yay. All right. So moving on, again, to continue the conversation around patient education and patient centrism, we do have some questions here from our perspective that we think would be helpful, again, both with what the regulations may look like moving forward, but also potential recommendations to the legislature. And we did have some materials that were sent along. They should have been shared with the group and everybody could see. But I guess the second bullet point, the second question is the most important one to me when it comes to patients, when it comes to public health. But and anybody can jump in with anything that they want here. I'm hoping to have an open dialogue. We certainly don't seem to have a problem with that. What is lacking? What can the program, what can industry do better? What can the state do better along the lines of patient education? And I think patient education has everything to do with the use of the product that they're being prescribed or subscribed a card for. What information should be made readily available to them? What should be on the label to help with patient education, patient knowledge of the product? Really anything that you think OMP can be doing better. What can we offer? So I'm just going to shut my mouth and let anybody jump in with anything that they think would help benefit patient education in the program. Heather.
So we actually utilize Dr. Sulak's patient education materials and find that to be extremely valuable. We also actually utilize that for like new employee education. So I encourage the state, Dr. Sulak, I'm sure, has been an amazing resource for the state over the years, and encourage the state to continue to work with Dr. Sulak on those materials. They're the best. I look at a lot of patient education materials across a number of states, and I have to say that Dr. Sulak's are some of the best that I've ever seen.
All right, thank you. Catherine.
I have to agree with her. I also use Dr. Sulak's materials, and I use it as part of my staff training. They all take his online webinars. On the other side, I mentioned it in prior meetings that I think that the OMP website is being brought up to a great level compared to what we've had in the past. And I think if you put a patient tab on there and add educational materials, what is the patient's options, from growing their own to using caregivers and dispensaries, and even the difference with the adult use, and then information about why testing is important for them or not, information about how to use cannabis, the different methods of ingestion, or links to services that give them the basic information. Trying to get into the law for a patient is not easy to read, not easy to comprehend for a lot of people. So bullet points of what they can and cannot do. It gets to be very confusing now that we have the two different programs. People don't understand what the difference is. So utilizing the state's website for patient education is going to be important. I disagree with putting patient education on the labels. I've tried because I thought it was a good idea. It is not. It's too cumbersome. It's too difficult to get labels that you can actually get the information on that people can read. You're talking about tiny little labels or very bulky packaging. So you have your labels on your jars, and then you have the accordion label, and then you have to also have a box to put the package in because there's not enough room on a tincture bottle for the information. So I would not put requirements for it to be on the product, but there could be a handout.
Yeah. So just a quick follow-up question before we go to you, Jamie. When you say we shouldn't put patient education information on the label, what exactly are you talking about? So we just understand what. Do you mean like method of use, or?
You can talk about method of use, but we're not doctors. So we can say this is how we do it. This is, what other people do, but I am feared that we're crossing legal guidelines if we put in there, take 2 drops and wait 2 hours and take 2. We're not doctors or pharmacists, and I don't know if we can legally say that. And where is the information coming? Because if my husband gives you directions, you're taking 1,000 milligrams. If I give you directions, you're taking 5.
So I guess back to my question, I can totally understand the argument around not just inundating everything on a label because, well, there's not room and you want to make sure that they see the important stuff. So what exactly are should we be leaving off of the labels?
I'm not sure what we should be leaving off. I know that we need to have like expiration, batch numbers in case they have any problems that can be traced back. Warning, I have a warning label on there, to keep out of reach of children and pets. And if you're using a sugar-free item, some of them can be toxic, deadly to pets. Not the cannabis itself, but the sugar-free stuff. Don't operate machinery until the basic warning information should be there.
Perfect. Thank you. Jamie.
Hi, thanks. So from in the prevention area, we talk about things like safe storage and disposal, or safe storage specifically, sorry about the disposal part, interactions with other medications, things like it is illegal to provide cannabis or a place to use to someone under 21 when it's not a medical product. Illegal to drive while high, to use in public spaces. And one we see a lot that people don't know about is that it's illegal for non-US citizens to possess cannabis under the federal law. And that we know in a lot of areas where there are new Americans that that they don't know about that, and that could be really harmful for them. So just from a prevention standpoint, those are kind of the list of things that we talk about pretty often.
Thank you, Jamie. Julie.
Hi. Okay, can you hear me? Good. So I think that Dr. Sulak's materials are outstanding and very, very comprehensive education. I think that's something that's a little bit too comprehensive sometimes for all medical patients to expect them to go through that kind of a program. So I think there needs to be some very, very basic, understandable sort of 5th grade reading level education available to every patient who gets a medical certification and becomes a medical patient in the state of Maine, and that the responsibility lies with the prescriber, or should, to be able to make sure that when they're writing a medical marijuana certification card for their patients, that they're educating them on some of the risks and benefits and some of the side effects, some interactions with medications and those kinds of things. So every patient that I do a medical card for gets a written paper with just some basics, some bullet points, some easy reading. We could potentially add a link to more education, for more information. We encourage you to go to and then have a link where there's a website for more comprehensive for people that are ready or looking for it or able to understand that. But some of the even basic education isn't happening for all patients that are getting medical certifications. And so there should be some sort of a system in place where we have something uniform that all of us can use to provide to patients, something that we get from the Office of Marijuana Policy that we can, add our own letterhead to or modify and add things to, but at least the basics that we can give to every patient that when we issue their cards.
That's helpful. You just answered the follow-up question that I had. Is it something that we can universally create and which you can use, but also have additional resources? So it's uniformed regardless of who the provider is. So thank you. I'm sorry,
Right.
you're still going.
Sometimes when we have handouts and we do patient education on any medication that we prescribe, if you give them 5 pages of information about their blood pressure pill, you've lost them in the first paragraph. So you do have to have something basic that's easy to use and understand and that is digestible, and then give them access to more if they need it. Another thing that's lacking from an education standpoint is the available resources for the providers and prescribers of the medical cards in the form of like CME, actual formal accredited education. Dr. Sulak's program is wonderful, but it's not free. And it doesn't provide any CME that you need every year to be able to renew your licensure. And in order for me to find the CME that I wanted to be able to have some more education, you can go to different states. State websites have some education. There are some available through some national organizations, but the state of Maine would be great if we had some sort of education for anybody who's going to be writing the medical cards that they have to go through that kind of helps them understand some of the laws, some of the main specific nuances of the medical program and what the expectations are on the part of the prescriber from the Office of Marijuana Policy. What are our duties in regards to patient education and patient eligibility, that kind of thing. So if we could come up with some sort of a process for creating that, that would be fantastic.
We might have to follow up with you on that one, Julie. That's good. So I have Chris, Sean, Susan, and Paul, and then Trish, and then I'm going to cut it off. And then anybody that wants follow-up, certainly let me know. But then we can talk about data and the role of municipalities. So Chris.
Just to, I guess, dovetail off what Julie was talking about there, we do in the city have a one-page flyer or a piece of education material that we require at the point of sales. One for both programs, the adult use and the medical program. But I think that's another potential avenue, where you could have that education pieces right at that point of sales. And we've had people that, again, put their letterhead on it and everything, but it's that same kind of consistent message across. So I can share that back with the group. It's a link on our city website as well with both of those documents on it. And then real quick, just you're talking about what should be, left off or what should be left on. Correct me if I'm wrong, but I don't believe the universal symbol that the OMP has adopted is a requirement in the medical program currently. I think it's only on the adult use side. At the end of the day, I think to be consistent across the board, to have the universal symbol in both of our programs in the state, I think would be beneficial, and to keep some consistency in the product across the board.
Yeah, absolutely. Well, it's not required. I know a lot of our registrants in the medical program do use it, but certainly not required, not on all products. So Chris, if you could send a link to David with that materials, I would love to take a look at it and just allow everybody to put eyes on it. So thank you.
Absolutely.
Awesome. Sean.
I like what Catherine said, and I also like what Julie said. I like what Julie said a lot. I come from a healthcare background, but due to my injuries, I don't carry the same amount of retention or ability. Just listening to you guys talk about 90% of what you guys deal with your cannabinoids and your testing and everything, it just blows my mind. I know when I come in as a patient, I come in looking for my medicine. And as far as education goes, speaking what Julie said, you can really lose a lot of patients within the first sentence, within the first paragraph, whether it's verbal, written, or whatever. You can't put this stuff online and ensure that everybody's going to look at it. You can't give it to them in paper and ensure that everybody's going to get to it. It's got to be something much like what we were talking with the proof of certification is, do we put it on, can we put it on our phone, or do we carry a piece of paper? It's got to be something that's going to be available for everybody to access, but really have it down to, I think, like the 5th or 6th grade level, or even have it where the facilities can give out a number, or you log into these things, and I don't care if you're getting looking for life insurance or health insurance or whatever. There's a chat button on there, and there's somebody that can answer your questions for you and give you a really simple lowdown on it so that you know what you're doing. Because as you guys I'm reading some of the stuff here where it's like, okay, potency in flower doesn't matter. It's like, okay, well, that's mind-blowing to me, because I know with my flower, I look at the test results and everything like that, and I know when I'm using it, there are certain strains and certain product that I use that help me with my stuff. And I microdose. I don't use very much at all during the day, but I know what I'm taking, and I've been educated on those things. I don't want to know more. I don't want to know less. You can overwhelm a patient really quick where they run from the information and they're just buying random flower because they don't want to know. So there has to be a fine line between overstimulation of education and understimulation of education. And you really can't you can't force it down somebody's throat, but it's got to be available to them, whether it's on a 1-800 Ask Pot question or a chat, press the chat button or something like that. I would highly recommend that, because I was craving it when I first, information when I first moved back to Maine, and I couldn't find it. For the life of me, I couldn't find it. And when we're talking about Dr. Sulak, for the first couple of years that I was here, I actually helped teach for Dr. Sulak. From the patient perspective and how to microdose and how quickly I got down to a very little amount of marijuana just by finding the right product to do the right job. You don't have to use so much. So it's really good idea to emphasize some way of getting the education out to the patients, whoever is producing the marijuana, whether it's from a caregiver storefront shop or a small mom and pop place that's doing an outdoor grow or indoor grow. They've got to get the information. And even if they just refer it to them, it's like, okay, this is what you're using. This is where you can get it. And I know what would be cool is if, okay, you get your vial or whatever it comes in, and it gives you the link, or it tells you call and this is the number, or you've got product 72 and you can call it and it will give you the lowdown on it. And it's so much easier instead of too much data overload, because I've got a traumatic brain injury and it quickly got too much for me.
Yeah, I bet. And that's a very good point to make. Thank you for that. So again, I'm going to go to Susan and Trish and then wrap up. Paul, I see that your hand's up. That can be a follow-up call considering we want to get to the next agenda item. So I'll go Susan and then Trish.
Some great ideas. The universal symbol in medical is voluntarily used by many of us. I like it just because it gives when I give a patient, most patients have, for me, they use THC products and they use CBD products. And it gives them a very clear indication. I'm holding in my hand the THC product. It does help avoid confusion. There is another symbol that I strongly dislike. There's one that looks like a stop sign that says "not safe for children," and I totally and completely disagree with that. I think it should be more like "keep out of the hands of children."
She froze when she was making a very good point. Are you back, Susan?
Products are not something we're just going to hand to children for their parents to give them. So I am. I thought I was still talking. Sorry. And I think I love the idea of OMP having links, and as long as it doesn't prevent the doctor and the caregiver and the patient from working on custom directions. I sent David a link. I sent David a copy of a spreadsheet, for example, for a specific patient that detailed their dosages of 4 different formulations. It's very complex and it can't be addressed by just a universal link to a document. It's a very individual process between doctor, patient, and caregiver. In my case, especially when you're
Yes. Oh.
dealing with, if you claim a potency on by a lab test. Thank you. I don't know how much came through, but
I think at that point we caught about 70% of it, but no, we can always follow up, but thank you. So Trish, and then we will go to the next agenda item.
Hi, I too like Catherine's idea of using the website, for a couple layers of patient information. First, straight up, here, you're a patient, here are your rights. Here's, basic information about your rights in the program. And then maybe secondary information about the products themselves and some of the differences like folks were talking about on the, THC alone versus a full cannabinoid profile product. That kind of stuff is very important for people to start learning. I also love what Julie said about the providers, and I think that would be a great place for, and if you do proceed on that, I'd love to participate, because there's lots of information patients need right off the bat, and it's hard to figure out where's the right point of contact to do that. And I do think at the provider contact, when you're giving them the card, is a great place to give them some basic information, including about the Office of Marijuana Policy. I find in my conversations, not a lot of people know Office of Marijuana Policy exists. So I think part of the education has to start with even that, what OMP is and where it is, the website, that kind of thing, and that they are the overseers of the program. And then last, until such a time that testing is incorporated as part of the program, I firmly believe part of the education needs to be that it is an untested program. In a Portland Press Herald article a few days ago that I read, I was reading the comments, and multiple commentators reached a consensus that the medical program was tested, and it was just like the same standards as the adult use, and that consensus was not, contested in like at least 4 conversations in the last month with both people from out of state who were patients coming here, 2 who moved here, and 1 who lived in state. None of them, they all thought that the program was tested. So, and then I read another article in another news, I want to say it was like Spectrum News. And again, they referred to the testing in the medical marijuana program. So I think obviously there's an information deficit out there, and until such a time that there is testing, maybe the #1 education priority should be letting people know that that is not true, because I myself have talked to a lot of people conducting business on the assumption that that is what's going on at this time because of the adult use program. Thank you.
Oh, yeah, no, and that is a good point as far as patient education and transparency with the program. Maybe we can think of some way to incorporate that feedback into the proposal, just so everybody has the chance to see it. But I appreciate all of that information. Just for next steps up to this point, I have calls back to Susan and Michelle retesting, call back to Julie re-provider education, and a call back to Paul re-patient education. But I certainly want to make sure that we have time to move on to discuss useful data and metrics. So I know we provided some of the metrics and data that we do have. Essentially what OMP has in the medical side is our licensing information and our compliance data. And then obviously, well, I shouldn't say obviously, it's probably not obvious, but we do have the legislative directive from 2018 to gather up public health and safety information from other agencies and community health organizations to be able to bring that into a central location and help make policy decisions moving forward. And we are in that process. But this was Paul's topic, so I certainly want to make sure that Paul has the floor and the opportunity to kick this conversation off.
Great. Thank you very much for getting us this data. I think this is really helpful for when I'm considering, what the program needs for rules. And, when I'm looking at, a lot of this data, it seems like the biggest problem that we're really running into is around compliance of caregiver assistance. And everything else, there doesn't seem to be a huge amount of issues with, including pesticide use. I don't see any patient complaints on here. Is that something that isn't siloed?
I'm sorry, I was muted. Vern can jump in and correct me if I'm wrong, but on that top line sheet of the compliance data where it talks about total counts and then inspections, within that are something like 400 complaints that we received in that time frame. And that we don't have, or we may have it, but broken down of who filed the complaint, whether it was a neighborhood, a community, a patient, another registered caregiver, a disgruntled employee, whatever it may be.
Yeah, just to qualify the data a little bit, folks, what you're seeing for data, the places where it's broken down on what the issues are that are identified, when it gets real granular like that, that comes from inspections of caregivers, not from complaints about caregivers or from patients or anybody else. And the reason that we have better data on inspections than we do on complaints is the systems that we use to track them. So we had to build a new system for inspections. So we built that up. It's providing us great data for resources like that. The other side of it, we're still working to better capture the data on complaints. Right now, we certainly investigate complaints. We can tell you how many there are, but we really can't get much more granular than that because we're the system that we're forced to use right now really just gives us a couple of options for closing out a case. And you'd have to literally get in and read hundreds of reports in order to try to make sense of that and get to this level of data that we have here. And I'd like to point out one other limitation that we have is, you have the data that we've collected, right? But there's a lot of data that we can't collect because we just simply don't have the tools or the authorization for it, right? So we don't have data to say how many people are using pesticides and how many products fail pesticide testing, as an example. That was one that was mentioned earlier. We don't have data to talk about even how much is produced in the medical market and how much is sold, to know whether or not there's any that's diverted out of the program or whether illicit marijuana comes into the program and doesn't actually go through a caregiver and things like that. So the data that we do have, I think is great, but it's definitely not all inclusive of so just keep that in mind when you're looking at it.
Definitely, because some of the data that really stood out to me is how you have the under the retail sales section, under retail store local authorization, there's a 98.5 compliance rate, which I think is pretty good. We're talking about retail sales, sales to qualified out-of-state patients, a 99.8% compliance rate. Record keeping, maintaining transfer records, a 93% compliance rate. Tax and wholesale compliance sales or purchases to or from non-caregivers, a 96.4 compliance rate. And then a tax and wholesale compliance, wholesale transaction records, a 93.5 compliance rate. What was troubling for me, but I can definitely understand as a small business owner, is the caregiver assistance compliance rate, which is a 69.8%. And when we get more granular into that, it looks like it isn't necessarily as much the expired caregiver cards. It looks like part of it is just, the employee's either not registered with the department or they just don't have the right paperwork filed. And that seems to be almost 50% of both of those complaints. So I think that's something that your agency has done actually a really good job on, is educating caregivers and educating people within the program about what is required within the compliance section. And I think that's also important that we need to, keep this in context with, people are running businesses and this is something that may not be expected of them. We're all expected to read the rules, but as, we all know, not everyone may have done that. One thing too, and I wasn't sure if this is something that would be, helpful for you guys, but you did have 12 new positions funded within the program for field investigators and field investigator supervisors. And is that something that that the department's been able to move forward with?
Yes, it is. We have started bringing in and filling some of those positions, understanding that the compliance team is where the rubber hits the road, and we want to build those relationships and essentially have them out there as a resource. So thank you.
Excellent. Yeah, it's I guess just the last part that I want to bring up with when we're talking about the data for right now is we're talking about, I'm referring to the I think this is the main health data. It's the long spreadsheet that comes from the hospital systems. And we're talking about between January of 2019 and September of 2020, the number of encounters and the number of individuals. This is on page 1. That is a cannabis related emergency department visits. It looks like the total is 24. And when we're talking about a program that has 100,000 patients in it, 24 is the same level, is close to the same number as emergency department visits for Tylenol. So we're talking about from a public health lens. If this is the data that we have and the data that we can operate off of, so we're going to operate off of data as opposed to anecdote or conjecture. I'm not seeing there being a huge problem with it from a public health standpoint, because we're seeing that, within over a year, there was only 24 reported emergency department visits. The outpatient numbers are different. But at the same time, I think that's just important to keep in mind when we're having this discussion about data and about public health and safety. Is this is showing me that I think the program is being very successful. And when we're talking about the education of patients and safe storage, I think that's something that is also seems to be working pretty well. With the other part that I think, I think actually speaks to your case, Eric, about the need for, metric, as much as I don't personally agree with it, is the idea of the trip ticket compliance, where there are a compliance count of 420, but only a 74.9% compliance count there. So one of the things from a rules perspective, and from operating, as a business operator, something that might be useful to us is if there'd be a way we could have a digital copy of this, or there'd be something digitally the department could offer for trip tickets. And I know that when I've brought this idea up to other people, there is concern that that data would go back to the department. I wouldn't have an issue with the department, for example, having data of how cannabis is transported between my store and facility, but it's just the idea of, it'd be a digital, something digital we could fill out that we could then provide to either ourselves or the employee that would be making the transportation. So we wouldn't have, triplicate forms that we would then have to keep track of and then keep them in a file folder to ensure that we remain in compliance with the program. It'd be a digital file. It'd be something that we could, easily access. It could be easily referenced. And it also could hopefully be easily cross-referenced. So if there was a question of whether a caregiver who is wholesaling to a dispensary or another caregiver, both parties would therefore have that trip ticket in a digital format that hopefully would be easily accessible to both the field investigator, the Office of Marijuana Policy, and both the caregiver and or dispensary.
I appreciate it.
But overall, this data has been very helpful. Thank you.
Good. Well, we're certainly going to use it to help build out those regulations where we can do a better job that would benefit, again, patients, businesses, and all stakeholders here. So I have Heather, Susan, Josh, Sean, Catherine. Then I'm going to cut it off because I at least want to start the conversation around the role of municipalities. But the one thing I will say about the public health data, I think it's been well documented in the newspapers as of late. Granted, the counts may seem low, but those types of negative health outcomes can be avoidable. So certainly from our perspective of the regulator, we're going to do everything we can to help reduce the increasing numbers, even though they may seem low to some people on this call. So Heather.
Yeah, I just wanted to kind of when we're looking at this data, particularly around this compliance data, I think it's important to remember a couple of things here. One is I'm looking at a little bit more of the details of this. And Paul, you mentioned that you don't feel that the pesticide issue is a huge issue, except when I dig down to it, I'm this isn't about whether or not someone is using a pesticide that might be approved. That's not what they're looking for compliance with. It's whether or not the applicator has been licensed or whether or not the employee has been trained. I don't think it necessarily gets to what I consider to be the major issue, which is there's cannabis out there that has pesticides on it that people are consuming and they don't know. So I think that it's, that we can get a false sense of security. I would also just add that working for a large multi-state operator, the majority of these numbers here, while you mentioned, Paul, these don't seem to be issues to me, these are huge issues to me. Anything that's in 95, 93, it's not acceptable in a lot of cases. I deal with situations with compliance risk in states that there are hundreds of thousands of dollars in fines for making these not super important mistakes. So I think it is I feel in a lot of ways we're lucky here in Maine in that we don't have the same expectations on our businesses that we might see in another program. So, at 83%, unacceptable. Now, and you're talking to someone who works for a company that there's public information out there that shows that we make mistakes all the time. So I'm only calling out my own company's programs in a sense in this, but those are not numbers that anyone that I work with would say these are okay with us. 99.8% feels a little bit better to me than a 94.3 or a 59.3.
And Heather, I'm glad that you pointed that out and made that comment, because certainly that's how we feel at the Office of Marijuana Policy. Our goal And I think part of it will be addressed with the more field resources, even though we'll still come far short of where we need to be with the education and be serving as a resource and technical assistance. Our expectations would be to have all of these compliance rates and at least 95% or plus. But thank you for that comment.
Yeah, just as an example, in North Dakota, the chief regulator, the Eric Gunderson in North Dakota actually reviews video footage from dispensaries on a regular basis. So we could have it a lot worse. I would also say that when I'm looking at this data, these, I believe, are inspections that people know are happening. So you know that these aren't surprise inspections. And the idea that we could have this much failure on an inspection that you know is going to happen, like what would possibly be happening out there if these were actually surprise inspections and you didn't know this was going to happen? So again, it's just a little bit more concerning to me than I think what, Paul, you're seeing from your side of it.
And just to, that's also a good point. Just to reiterate what Vern said, these don't incorporate the over 400 complaints that we did receive. These are inspection data, and we have formed the first proactive scheduling of inspections. The program is seen, I think 2 years ago, but I want to make sure that we have time to get through these last four: Susan, Josh, Sean, and Catherine. Cut it off, and then start the conversation. At least start the conversation around the last agenda item. So, Susan, fire away.
I was thinking about the caregiver problem, caregiver assistant problem. I'm going to talk, my internet's going to get unstable, but I was wondering if there was a way we should be maybe making the caregiver assistant card an annual card for a person, and then when they take a job with a caregiver or a dispensary, they could then affiliate with them. Like you could pre-qualify a person as an assistant, and then when they take then they could take a job right away. Like they could come in to apply for a job, have their already cleared caregiver assistant card instead of waiting 30 to 60 days. I mean, the limit that creates, they're going to take another job if they have to wait 30 to 60 days to even start work. And I also think that people who have been in the business for years, like someone, say a caregiver or a dispensary has been licensed in the state of Maine for 6 years, maybe their renewal could be for 3 years instead of annually. You know, you just finish an application process, you wait 45, 60 days for your renewal to come in, and in 8 months you're starting it over.
Cutting out again, Susan, but all points well taken. And I know I think everybody on this
license through the department. I'm taken.
Yeah. No, and I will say, to help address some of this, I know a lot of people on this call in the Office of Marijuana Policy supported the one card. Well, technically it would be the 2-card system. And I think maybe next weekend we can come back a proposal for that. That would certainly help alleviate that and hopefully help with those compliance rates. So I'll make sure to write that down for next week. Josh.
Yeah, so just touching on kind of using data for decision making generally, and compliance data in particular that we've been talking about. I feel like that information might be a little bit misleading because, again, the OLP is able to gather data right now from kind of two sources. One is the licensing process. The other are scheduled inspections, which everybody knows can't possibly cover everybody every year. It's a fraction of the program that gets visited yearly. And so, not to loop back to the previous topic too heavily, but without any mandatory testing requirements and without any track and trace requirements, how do we really say with any certainty or any confidence that there aren't these problems in the program? That's all conjecture when that information is not gatherable in a comprehensive way within the current program structure. We need to understand that, a lack of collected data is not the same thing as a conclusion. Additionally, with the emergency room visit information, obviously, any numbers in that area are not great for our industry, and we want them to be as low as possible. Again, I think it's a little misleading because some of the issues that we're talking about in relation to public health and safety and products, pesticides being used on products or dirty products making their way to the market and the consumer not being aware. Those are things that may not have immediate or acute medical reactions. Those are things that may build in a person's system for 10 or 15 or 20 years. And saying we don't have the data because we're not seeing thousands of people flooding the emergency rooms is, I think, a bit of a misnomer, because we may well see a balloon of problems 10 or 15 or 20 years down the line if we don't get more proactive. Politics and government are naturally reactive. That's the way the system works. But we have an opportunity to get out in front of these things and improve the quality of for the patients overall. So I think we need to understand the limits of the data that we currently have in front of us in order to understand the context of the decisions that we're making. I'm not advocating that we say we don't have enough data, thus all of the regulations need to be in place immediately. But I think we need to be talking about that openly.
I will agree with a lot of the comments here. It's very well said, and I wish Jamie was still on the call, because that's a lot of what we've actually heard from our public health partners and the work that we do with them, pointing out that it might not be an immediate health crisis. But anyway, we have heard that from public health, and that's a point very well made. So I'm going to go to Sean to close it up, and that would leave a follow-up for Catherine's topic. Wait, was Catherine part of the queue? Okay, sorry. I'll go to Sean and then Catherine, and then anybody else will do a follow-up.
I'm gonna go off of what Josh and a few others were saying about the data. Is just because it's not available doesn't mean it doesn't exist. To compare the amount of people that have had complications with cannabis to Tylenol is kind of ridiculous, since I mean, honestly, anybody on this conversation, if you've been in the cannabis industry for any amount of time, know people that have had complications that have not gone to the emergency room. Probably more than 1, 2, or 10 or 20. I myself have had an edible that I've spent hours, over 8 hours in the bathroom, just unable to move with my head in my toilet, praying to God that I'm going to die, could barely breathe, couldn't get enough air out of me to scream for help. I never went to the emergency room. Would I qualify for one of these statistical to maybe put it over the Tylenol reference? Possibly, but we can't use data to support a faulty system of not collecting data. When I can't, what was the gentleman's name that was on here? The other guy from the state. I can't see his name on here. Vernon. Okay, Vern, down on the bottom. From what I understand is the patient information is not being collected or able to be seen or tabulated in such where I've had a medical reaction to flower or to cannabis or to an edible or to a tincture or something, or a roster of complaints. I mean, you can get onto WebMD and you can look up any doctor and you can find out the complaints to that doctor. But do we have a system where we can do that for caregivers put out by the state and everything like that? It just, the data is faulty. Just because it's not there, statistics, you can't use statistics to support your agenda if we're not getting the data that we need to go and show you that it's not accurate to claim that it is in such a way to allow you to continue the business that you're doing by using the data that just helps you get along the way you're getting along. Because we patients, we want the data. We want to see this more clearly. We want to know who's putting clean stuff out, who's putting the stuff. Every time they bring in a test, are they getting hit for mold or other stuff? We want to know that, but it's not there.
Thank you, Sean. And then we'll go for Catherine, and then we'll wrap up the conversation around data.
Hi, so back to Paul's comment about the electronic trip tickets or the metric, that the electronic trip ticket would be helpful, but we do also need to remember that we're not putting addresses of patients on there for patient privacy. I'm going to keep going back to that every time we come up with a rule, whether it's the metric system or the paperwork. Patient privacy is number one. Not all patients want to be part of that data that's collected, and that's why the patient registration with the state was removed, because patients didn't want their information out there. So we've got to be careful with that. The data that we're collecting on the caregivers and the dispensaries and such, it needs to be put into forms that you guys can use. And I think you probably have enough analysts there that can figure that out. I want to be really careful around the patient, the patient data, and also wondering, as far as the inspections that they're gathering the data from, are we standardizing the inspectors? Do we have like a checklist of the regular inspections? Obviously a complaint is different. But for when you're scheduling these inspections, do we have a standard list that the businesses that are part of can go by, that can provide you with the information that you need, and that all the inspectors are looking for the same thing? Because I've had a couple of different inspectors, and I had one inspection where my packaging was fine. And then I got a call from one of the customers that I wholesale to, and the packaging was not fine, and that they had to pull it from their shelves, and we had to make changes to the way that we did the packaging. And so if for actually 2 inspections it was okay, and then now it's not okay, we're getting conflicting information. And we want to do it right. So we need to have specific expectations so that we can comply with that. And I know that's part of the rulemaking process, but yes and no, it's not all there. So we can't be held accountable for stuff that's not there.
So to your point, as far as consistency, we do have a compliance system that is built out that is the same for all inspectors. I cannot speak to the scenario with your packaging and labeling, although I will speak to the point with the current regulations. There is far more ambiguity in there than we would like. Again, speaking to that shared understanding both between the state and the industry themselves. But yes, we do have that, and we're certainly working towards that. We want you to be able to go to anybody with an OMP and get the same answer of the same question. And with a larger organization, that presents more challenges, but we're definitely working towards that with the systems that we have in place. And then I will just say, to your point, we've taken patient data incredibly, we've put a high priority on it. And as you all know, we don't have any of it. And we'd prefer to keep it that way. So I'm going to wrap up the conversation. We'll go back to see if there's any next steps or anything that we can do in the interim to help move this forward around this conversation. And then I can report back at the top of meeting number 4 in 2 weeks. But I want to make sure that we have the time for an agenda item that was thrown out in the first agenda to talk about the municipality's role within the medical program. I know there is some ambiguity and different interpretations across the state, but I'm hoping that Rebecca and Chris really being boots on the ground, and Rebecca working with a number of municipalities across the state, and kind of speak to what you do. What are some of the challenges in your job, and what are some of the opportunities for us to bring clarity and help our municipal stakeholders interact with this program as well. So I'll turn the floor over to whichever one wants to jump in.
Get started if that's okay, Rebecca. So in the city of Portland, I serve as the marijuana compliance coordinator, and that's a newer position in the city. When we drafted and enacted Chapter 35, the marijuana business rules, business license rules. So I think one of the key differences that I see between OMP and how we kind of have it structured in the city is that code enforcement piece. I'm a state licensed code enforcement officer. And so not only are we looking at I think your office does a phenomenal job working on the license side of things, but we are looking at building plans. And, when we're doing our site inspections, sometimes I think our 2 offices potentially look at different items and different things. And I think there's some value in having those two different kind of sets of eyes or different roles in that operation. So in the city, I do both programs actually. So our ordinance does cover the medical program and the adult use program. So for me personally, sometimes it's a little challenging. Which set of rules are we looking at today for the different projects, just because we do kind of go back and forth between the two. I've heard a lot through these last two that, the testing, it's not going to be exactly the same, or some of the regulations, won't be exactly the same. And I don't think the two programs, to mirror back to back, they serve different purposes. So, but anywhere I think we can try to line up, you talk about the testing, the standards, they're tested to that same potency, or the qualifier is the same. So anywhere I think we can line those two operations up, I think is beneficial. And then I think just anywhere that we can communicate from a municipal end back to your office is beneficial as well. Right now on the adult use side, when somebody is opening a new operation, part of that is that local authorization. And although I think that would be great all the way across the board on the medical side for a couple different reasons, I don't know if that's 100% where we need to be at right now. So, but I do feel like when there's a business component tied to it, potentially a local notification process, maybe something we could look at. Because I think when there's that kind of business component tied to it, it is an industrial operation at that point. I'll use an example is, we went into a facility yesterday that OMP was leaving, and that facility was good on the state end of things as far as their licensure. And we didn't know at the city level that occupancy was even there.
Chris, I'm sorry to interrupt. I'm really lost. Are you talking about like adult use or medical?
Medical. In the inspection we were at yesterday, sorry, in this example, yes, yep, sorry.
I think I understand what you're saying, and I'll just call. So the city of Portland has obviously their own licensing requirements for adult use in medical. Does it have to do with, and we get these conversations and calls all the time, has to do with the confidentiality within the program, so you don't know which registrants are operating within Portland, so you don't know how to proactively have them go through the licensing? Or am I going way up?
No, sorry, Eric, I think you kind of summed it up there well. And, it's that they can be, their license can be fine at the state level and there is no issues there, but sometimes at the local level, we don't even know those occupancies are there. So I think that potentially puts everybody behind the eight ball, us as the municipality and the applicant, if they think they're in great standings and with a community, they potentially are not.
I understand what you're saying. I will go to Heather. Unless unless Rebecca wants to jump in. I obviously want to give the two of you some of the challenges and opportunities that you see.
Yeah, well, I'm happy to let Heather follow up with Chris. I mean, I think one point that I probably should make, we're not boots on the ground by any means. I work in the legal services department of a municipal organization that deals with a variety of different legal issues for municipalities, one of which is marijuana. But this has become a pretty frequent question that comes up in municipalities or municipal officials that we deal with. So I guess my perspective is a little bit different, I think, than Chris, who is coming from a city that has already developed pretty extensive regulations on both of these the medical side and the adult use side. I think that we are primarily dealing with municipal officials who come from municipalities that don't want to regulate, don't want to opt in to certain types of commercial establishments under either law, or maybe have limited regulations, but don't have a lot of resources to really fully implement those regulations. So the question always becomes, what is it? What kind of activity is this? Is it, something that rises to the level of commercial activity that would be subject to municipal opt-in, or is it another type of activity that might be authorized under caregiver registration at the state level that municipalities can't necessarily prohibit or limit the number of, but they might be able to regulate. So there's a lot in our office. There's a lot of confusion, it seems like, around what type of caregiver activity can be regulated, to what extent it can be regulated or not. So I guess I'll just put that out there, and we can talk about, opportunities or potential methods of kind of helping or assisting with that in a minute.
Yeah, absolutely. Thank you for that. So Heather, I got Heather, Paul, and then David.
Awesome, thank you. So I think, from my perspective, and I think I was the one that kind of first raised the municipality challenges. So I think, from my perspective, what I'm looking at is opportunity, and MMA does an awesome job of this. I'm not sure if the disconnect is between the municipalities that don't realize that MMA can help them, or if it's just a smaller municipality who's kind of listening to residents that maybe don't actually know what they're talking about. But I have been kind of helping out some smaller communities with figuring out like how to move forward in pulling together some kind of an opt-in, whether that's a limited opt-in, only wanting to do certain businesses, which a lot of municipalities don't want to touch retail stores, but are comfortable with cultivators, or don't only want to do caregivers and don't want to do anybody else. And I would love to see some kind of like training, even if it's like a video training, like Eric, you getting up there and explaining to municipalities like what they do have the right to do and what they don't under the law. And again, Rebecca, your group has done a great job at trying to get that information out there, but I'm not sure that it's kind of hitting the mark. And then I also have to say, to Chris's point, like lining up the standards would be extremely valuable for municipalities. I think that they need to feel a level of comfort. One of the things that I worked through with Hollis was how much we are going to rely on the state and their approval process versus what we need to do extra in our municipality. And I know that Portland has come up with a very robust set of requirements. And Chris, I work with Tammy over here in Hollis, who I know that has done, has worked with you over in Portland. And she's kind of shared with me a little bit of like what's happened in Portland. She's our code enforcement officer now. Haha, we got her. And, somebody as sophisticated as Tammy, who's really, she's worked in a number of different municipalities that have different aspects of cannabis ordinances in their towns. It is still very complicated and very challenging when municipalities are doing this first. So some kind of training video, something that gives municipalities a little bit more of a level of comfort around what they're doing, lining up the standards, I think would be really helpful. And then possibly some like specific training that goes to code enforcement so that they feel like they are getting that they are doing what they need to do. I know for us, we rely heavily on our code enforcement officer and her like review of things. And if Tammy says it's okay, then me as a member of the planning board, I am much more likely to say, if Tammy says it's okay, I feel confident she knows what she's doing. I think that could be helpful from the municipal level. And then maybe just some more like information for municipalities. We do have some resources available. Here's how MMA can help. Here's how OMP can help. That might also be beneficial. And I'll shut up now and let Paul go.
I think your point to the code enforcement training is a good one. It's something that we've talked about internally. I don't think the burden falls on Rebecca and MMA and having trainings. I think really when I talk about challenges and opportunities, it sounds like we just need a little bit more clarity for municipalities in the way they interact with this program. And Chris has highlighted a challenge. So it's certainly for this group to discuss, and I guess OMP to come up with another proposal or however it manifests itself.
Dedicated contact person would go a long way, I think, when a municipality feels that they have someone that they can build a relationship with to ask their questions. They'll remember to call, whoever it might be. That could go, I think, a long way in helping municipalities feel a little bit more comfortable around moving forward with opting in.
All right. I have Paul, David, and Catherine. Rebecca, I'm going to let you go. I just saw yourself come up.
Sorry, I didn't mean to unmute. I should have raised my hand. I guess, just so everyone is aware, I mean, we do all of those things, Heather. We have videos, we have resources, we have information. It does go to all of those, municipal officials that ask the questions, directly. We don't have control over every single municipality and whether or not they choose to use our resources either, but it is available to them as long as they're members. And we try and make it as straightforward and accessible as possible. So
you guys do a really good job. I don't want you to feel like I'm saying that you're not doing a good job with this. Trust me, I use your materials a lot, and I always recommend that people look at MMA materials as well.
Yeah, and I guess I'm not taking that away from what you're saying either. I guess I just want to make the point that we are sort of limited in how, what everybody does with the information that we try and give to as many people as possible.
So just a quick time check, 3:56. We're certainly going to go a few minutes over. If you have to drop off, completely understand, but I want to make sure we get to Paul, David, and Catherine. We'll put a bow on it, and then we'll quickly talk about next meeting. So Paul, fire away. Unmute, Paul.
Thank you. As a member of my planning board, one of the things the chair really imparted to me and other new members was the fact that Maine has a very strong home rule authority. Maine has a lot of ability, has in the Constitution, has given a lot of abilities for municipalities to decide what they want to do within that, within certain boundaries. This is different than some people who have encountered a county style of government where the county has a lot of power. So that also can add, I think, some confusion and variations between, not only what municipalities do, but what also people who come to operate businesses or open businesses can expect. From my experience, like I think as you said, Rebecca, is that municipalities do tend to have a lot of very limited resources. We don't receive a lot of funding from the state. We don't get a lot of revenue sharing. There's no local option sales tax for cannabis or any other products. So that leads us to be very limited in what we can and can't do. We've looked at, offering additional, fees for regulations, fees for inspections, specifically with cannabis. But what that turns into is then it turns into a statutory conflict where can you really charge that much? Does it really cost that much money to have the code enforcement officer to come in and look at it and do all these things? And at the same time, we also lean on the state a lot. I know that when we're dealing with things like shoreline zoning, we have to work with the DEP a lot. We've talked about, I think, Chris, I think you sent a document around talking about the fire marshal being able to offer a program for municipalities. Is that correct, Chris? To be able to kind of skip that?
Yeah, that was, I wouldn't say skip it, but when we do fire plan review, it covers portions of the state fire marshal's plan review. There's still portions that they cover as well, but it shares that authority, I think.
Right, but that's so, but and that from my cursory read of it, that gave the municipalities, kind of just more, if they wanted to go through that program, more ability to not lean on the state fire marshal and be able to do it themselves. With that being said, our municipality, I live in a very small town, has very limited resources. Our code enforcement officer is shared by 13 different municipalities. So when we're talking about getting a code enforcement, getting a code to be, verified, it can be quite a while to get that taken care of. So our municipality has taken, a very hands-off approach to some things, but we still have a lot of tools in our toolbox to be able to address this. The road commissioner in our town works very closely with the planning board. So anyone who wants to add sort of any ingress, egress from the road has to go through us and the road commissioner. And also, is anyone familiar with Form 1069 from a planning perspective? Has anyone else dealt with that yet? It's what CMP requires to be able to get power hooked up. Because that's been something that's been something that I've encountered the most in my time on the planning board, is that people have come forward and asking for Form 1069. And so that is something where generally we understand, we generally ask them what they're using it for. We want to make sure they meet all setback requirements, et cetera. And that's been something where we tend to discover where people are doing medical cannabis cultivation. Recently, we approved a Form 1069 for our first adult use cultivation facility in town that has conditional approval, and I think is moving towards municipal approval right now, which is very exciting for our town. With that being said, it's the municipalities, I feel like we're running into this urban-rural divide. And right now, I know that there are some municipalities that want to be able to have more power. And I think they do have that ability, but that's something that's going to, again, run into conflict if every municipality might want to do something differently. So when we're looking at the idea of shared resources, the idea of the state trying to put any sort of additional mandate upon the state, upon municipalities, I think could potentially slow things down. One reference thing is shoreline zoning, which I believe was something that has been required by the state for over 5 years. And our municipality just finally got our plan to the DEP because it took us that long to get it there. Sometimes we have trouble with even, getting enough people to show up for a planning board meeting to have a quorum. So when you're talking about having additional regulations mandated by the state to where a caregiver or a dispensary would have to go before a planning board, in some of these rural areas, you could be talking about having to wait months on end even to get a quorum to be able to have, your application or whatever form you're looking at to be reviewed. There are ways that, planning boards can, I think, get around that. But at the same time, that's up to every different municipality. So when we're talking about something as simple as Form 1069, just being able to get power, this could be able to have CMP come hook your power up. And that's a whole other animal, trying to work scheduling with CMP. You're talking about something that could potentially take months if you're in a small municipality. So when we're looking at this, I think it's also important to look at the data that we have right here. And when we're talking about the idea of local authorization, I didn't see anything about manufacturing on here, which I do believe requires an opt-in unless it was before 2018. That's correct, right? Vern or Eric, before December 2018, you would have to have be operating a manufacturing facility. Other than that, your municipality would have to opt in. I just want to make sure I'm not misremembering this.
Yeah, you're talking about the grandfathering position.
Yeah, grandfathering. I just didn't see anything on the data right here about manufacturing facilities that were part of the local authorization. But I think what this data here shows me is, when we're looking, I'm sorry, there is manufacturing. The manufacturing local authorization has a 94.6% compliance rate. And only 2 of those didn't have any local authorization. When we're looking at retail store authorization, that's a 98.5 compliance rate. So I think the tools that municipalities have right now to address manufacturing and retail are there. And I think they're actually being used pretty successfully. One of the issues we're dealing with now is someone who isn't in non-compliance with one of our ordinances. And they're facing, not only hefty fines, but their property might even be seized by the municipality because they refuse to engage with us. So when we're talking about, issues that people will encounter, I think that the tools are in the municipality's toolbox to be able to handle that. If it comes down to an issue of reporting or of municipalities knowing where certain facilities are, I'm not sure if that's something that can be addressed statutorily, if that's something that can be addressed in rule, or if that's something that's just, a staffing issue. I know staffing is an issue for a lot of people right now. So with that being said, it goes back to my original point of the urban-rural divide is I think happening when we're having this municipality discussion. And I think it speaks to the fact that we have a system that seems like it's working well, because the urban areas do have that ability to zone and code things more strictly than the rural areas. And if the rural areas want to go that route, they're allowed to. Because I know that we just had a whole fight over here about a ordinance concerning mining and resource extraction. And that was a very divisive issue in the town. So divisive that a lot of people don't even want to return to the subject matter for the next town meeting. But that's something that I think could be the same with cannabis, is that if the municipality wants to enact a stricter ordinance, I don't see anything that prevents that. And whether that's a sight, smell, or sound ordinance, whether it's a land use ordinance, I think municipalities have those tools in the toolbox, and they just have to be able to use them. And a lot of time that involves going to town meeting and having it being approved by the voters.
Thank you. So I want to make sure, again, understanding we're 5 minutes over and being respectful of the time, Dave, Catherine, and Rebecca, and then we'll talk about next meeting.
Thank you, Eric. I'll be super brief. And I just, as I sit here on our third meeting and I start to think about what we're here for, when this program was rolled out, the definition of a caregiver has definitely morphed today, right, into what it was. And there are still very small, caregivers that are operating out of their home. They're very focused on a few patients. And then there's some of us, and I'll speak for myself, who operate on a much larger scale. And for someone like Chris, who of course is in the city of Portland, I'm sure Chris gets, complaints from neighbors who are upset about smell in their neighborhood and things of that nature. I think there's a difference between those of us that operate on a larger scale and those that, operate out of their home. And my hope is, Eric and company here, is that we can all agree that there's a difference. And so I think it's so simple sometimes, yet we try to make things convoluted just because we try to take a blanket statement for everything. And it just seems simple. It seems like if you're a home caregiver, that's a very different thing than operating out of an industrial building in Portland, Maine, or in any town for that matter. And so from where I come from, I would, I'm sure the people on this panel look at me and think I'm crazy, but I feel the regulations, maybe testing requirements, any tracking on someone like myself, yeah, I should have to be a part of that. But maybe someone on a much smaller scale would not have to fall into that same category. And so, Eric, I just hope we're mindful of that in these conversations, because I know all of us really want to see the small home business, the people that have, kind of the grassroots that have built this industry up, never get that taken from them. But those of us that do want to operate on a larger scale, operate in a way that the cities and towns know what we're doing, okay? We're following, rules and regulations and statutes and ordinances. And I just think it's that simple. And, that might cover a lot of things that sometimes we as a group of caregivers butt heads with, because, we're trying to protect our friends, our small, some that are much smaller than us. And when you've got some size to your organization, you should always look out for someone who's smaller than you, right? If the small folks go away, we all lose. That's a big, big deal, right? And so I think that's something that we haven't really said in these meetings, is that we all recognize there's a difference, but maybe that's how we can sort of flow these things through. We can help the cities and towns have more understanding of what they're looking at. And at the same time, when we start to implement or try to implement some of these changes, maybe we roll it out initially towards those of us, and again, I speak for myself, that operate some of the bigger operations. That's all. I just wanted to I thought that brushstroke might cover quite a bit of what we've been doing.
Yeah, no, point very well taken. And I think that's something that we have an eye towards with these conversations, what regulations may look like or recommendations back. We did attempt some sliding scale model essentially in the last regs. We may have gotten close. We certainly missed the mark overall, but well taken and absolutely heard.
Thank you.
Catherine and Rebecca.
Thank you. I've like I said before, I've worked with several different towns as the trade association education director. I've gone to a lot of different meetings, and they have said that they're not getting responses in the time that they need them. And I know we've got new staff members on board, so that should alleviate some of that problem. But when they were going to their ordinances and trying to create their rules, they didn't have a clear source. Not all of them are part of MMA. Either they're too small and they just can't afford it, or I don't know what the reasons why they're not part of it. But I'm wondering if with some of the excess program funds, maybe a customer relations or a community relations person could be there to offer ongoing training to municipalities or service personnel that deal with the cannabis industry, you know, maybe like a quarterly or a biannual training. These rules, I teach the classes for the trade association for caregiver law and business setup and stuff like that since 2012. And that's all well and fine, but for the communities, they need something like that. They need a update, because the laws change every year. Every single year that this program has been in existence, there has been at least one law change, if not 24. And so for people who are not participating in it, they don't understand. The law states that a municipality may not prohibit or limit the number of caregivers. They don't understand that. They don't know what they can and cannot do. And it really becomes over-regulation between following all of the state regulations, and then you have your municipality regulations. As a business owner, it's really hard to follow. And I found myself falling out of compliance for saying, okay, well, we're going to just do this, this, and this. And then somebody in my office is like, I don't think we can do that. I'm like, of course we can. And then it's like, oh my God, no, we can't. So if I feel that way and I'm here all the time participating, these municipalities are going through a lot trying to figure it out. And in turn, because of that, the business owners are having a hard time complying. I've had people reaching out to me saying, well, my town doesn't prohibit caregivers whatsoever, so I'm going to open up a store. I'm like, well, did they opt in? And they're like, well, what do you mean? No, there's nothing on the record that says I can't. I'm like, well, this is one of those weird rules that somebody just happened to throw in at the last minute, so that the towns have to actually opt in instead of what they normally do in opting out. So there's confusion as far as some of the businesses not having their permits to operate. I've had some people that actually opened and they're like, what? How would I know? It's not clear, and there's so many law changes that it's not out there. And some of the municipalities, if they call, they're like, no, I don't think so, because they don't know either. So regular updated training for those people would be helpful. We've got to stop some of the overregulation and the unfairness in the local application process. I mean, look at Kittery. I know I'm not the only one. I've had some people that have mentioned it to me, as far as they put out a lottery or a raffle for their thing.
Understood. Let's stay on medical marijuana though.
Right. Well, I'm just saying it happened in Hollowell with me. Again, it was a lottery for the medical marijuana. For a specific location in town. Yes, I did it, but it doesn't help the small guy. I wouldn't have been able to buy multiple chances at that lottery by setting up multiple businesses and applying multiple times. But there are clearly some people that do. Hollowell is probably not the biggest town to go after, but you know, I just think that some guidance would help.
And I will let Rebecca take us home before we talk about our next meeting.
I just wanted to circle back onto one of the things that Chris mentioned initially, that seemed to sort of get to one of the other agenda items, which is, you know, opportunities to try and address some of these issues. And that he had mentioned a local notification of commercial activity, kind of that kind of process where there would be communication between OMP and municipalities. I think that information is kind of key to the confusion, or to addressing the confusion issue and addressing the miscommunication issue. If the municipalities have the information that they need about the caregiver operations and when they rise to the level of commercial activity that would be subject to more regulation than the smaller operations, then I think that that would be helpful for municipalities. So like some sort of local notification process for that type, when that activity rises to that level, I think is a good idea. It just seemed like something that would help. I guess the other point I wanted to make too is that, you know, each municipality is going to be really different how they choose to regulate. One, you know, central organization, whether it's OMP or MMA, sort of, you know, lording over these regulations or telling municipalities what to do is just not feasible. It's not going to work. Each municipality is going to decide what they want to do themselves. Some might want to regulate certain ways, some might not, you know, want to regulate at all. Some might want to establish a lottery system for selecting the types of establishments that they want in their storefront, or in their downtown. Others might not want to others might not have zoning at all. Some municipalities don't have zoning. So it's I think it's just important to keep that in mind too, that every municipality is very different. And that's not, and the way that they regulate caregivers is not, that's not a unique thing to caregivers. I mean, I think municipalities have different regulations for everything. You know, some choose to do local land use ordinances, some have very minimal land use ordinances, some don't have business licensing, some do. So it's different for everybody. I think that one of the key ways to if you're having issues in a municipality about how things are being regulated, I mean, I think that one of them, I think it was maybe Paul that mentioned it, going to town meeting, engaging with your municipal officials, that is, I think, one of the basic, most fundamental ways that you can try and address some of these issues. It's not going to come from the state, it's not going to come from MMA, it's going to come from the municipality, it's going to come from the people who are in those municipalities. So that's not necessarily a rulemaking issue, but I think it might address some of the problems that some people are facing.
No, and I think what you said at the very beginning of your comments really hits the nose on the head for this to help alleviate a lot of this unclarity in what roles, and there needs to be some level of information. And to Dave's point about the larger operators, you can just show by hands, we don't need to have a conversation about it, but would anybody have any objection to OMP being able to share very basic information about commercial medical operations with municipalities? Paul?
No, I wouldn't have a problem with that, but I guess my thing is it kind of comes back to when we're talking about what sort of statutory changes might need to be suggested. I think David brought this up, the idea of scaling it. So right now, since there's only, you know, 2 categories of caregivers, there still isn't, or 3, the unregistered, the plant-based, and the square footage base. It would be almost like, you know, how do we determine what is a home-based caregiver versus what a commercial level?
That's a very good point as far as, well, what would we define the commercial entity being? Yeah, for sure.
But I think it is a good idea for municipalities being able to check if there is a commercial operation going on through the Office of Marijuana Policy.
All right, we're going to Susan, Heather, each hopefully do it in like 30 seconds, and we'll talk about the next meeting.
I was the same conversation as the difference between when does it rise to a commercial level, but also that it's currently a law issue because of page 28 of the statute, where the confidentiality, OMP can't just release the names of the caregivers to
this would fall into the bucket of
the current moment in time.
Consensus recommendation to the legislature to help alleviate this issue. So Heather, real quick.
Yeah, I mean, we implemented you got to have a home occupation license in order to operate. That's what our municipality did, because there is the issue around code enforcement not knowing who's doing what. So I 1000% support any effort that can help make it a little bit easier for municipalities to understand who's licensed and who isn't.
Perfect. Thank you. I can't believe we got that all packed in. Granted, we are 18 minutes over. I do apologize. Again, I've said it 1,000 times. I appreciate everybody's time and know it's valuable. So our next meeting, I believe, is in 2 weeks, 3 weeks. And again, we'll have David send out a request for feedback on that 5th meeting, because we still have topics that we need to talk about. And some of the bigger ones that we still haven't had a substantive conversation about, and I would love everybody's feedback. Obviously, we should dip our toe back into packaging and labeling requirements, the importance for those. We have to talk about tracking. We need to talk about tracking, whether there's a consensus or majority consensus or not. Business entities, but does anybody have anything else that they would like to jam into a fun-filled adventure in 3 weeks in our next meeting? Because again, the idea is to have the 5th and final meeting really be our opportunity to go over what the outline or structure of a rule would look like moving forward, and what some of those recommendations to the legislature would be, those 2 pieces. So Paul.
So I think it's like, for when we're talking about sales data, it is what does OMP want for data? And then would that be like a rule or statutory change? And then I think when we're talking about I think I want to talk about some data tracking, so we can make it get more granular, because I feel like that would really tie well into the tracking discussion also. So it's just, this data has been very, very useful to me. And when we're talking about the fact that caregivers had almost $270 million in sales last annual in 2020. I want to be able to try to make that data more granular, so we can make better decisions as a work group, as an industry, and as participants in this program.
Yeah, we can shoehorn that into the conversation around tracking, if that makes sense. Yeah, we can make room for that. Heather?
I was thinking, there is a little bit of a challenge around home-based caregiver and storefronts, and really, what qualifies as a storefront, what doesn't. We may want to talk a little bit about whether it makes sense to put some more meat into defining what makes something a storefront versus what makes something not a storefront, but you still have a sign outside your building that says dispensary, even though you're a caregiver.
Yeah, and then we can again circle back on Dave's point and Susan's and Paul's point about what if we had that sharing of information of a commercial entity or a storefront. So conversations around definitions of registrants. Okay. Anything else? Well, if you think of anything in the meantime, feel free to email David. But with that, I think we can come to a close. And again, thank you for all of your time, for going significantly over. But I think the conversation was, well, I know the conversation was incredibly helpful on our end for what we've been tasked to do. So.
Great meeting, team. See you.